everyone. My name is Samantha Ski with University Research Co., or URC. Good morning, good afternoon, and for some of you, good evening. We are pleased to present today's webinar on COVID-19 and contextual adaptations to community-based psychosocial support interventions for trauma-impacted communities. This webinar is being carried out by USAID's Health Evaluation and Applied Research Development, or HERD project, with co-hosts the City University of New York Center for Innovation in Mental Health and East Central and Southern Africa Health Community. As we begin today, we want to share a little bit about the HERD project and the work that we do to bridge the disconnect to catalyze evidence-informed action. So this work aims to address the common disconnect between evidence users and evidence producers, where these groups access different networks, have different priorities driving their research agendas, and have differential access to information and evidence. And so there's a real need to foster connection and collaboration. We work to do this through our Implementation Science Collaborative. The collaborative works to accelerate evidence-informed action by enabling the right mix of partners, carrying out agendas and agenda-setting processes that reflect the priorities of decision makers and local contexts, and carrying out research and evaluation studies and developing products from that work that effectively communicate evidence to decision makers. And in all of this, we work to develop and strengthen knowledge sharing networks and sustainable learning collaborations for stronger ongoing learning. The HERD project and the Implementation Science Collaborative work across 7 thematic areas, developing these networks of networks. Of course, in this webinar series, we're focusing on our mental health and psychosocial support work. The work that we're doing in this area stems from a priority identified in a recent systematic review, which found insufficient evidence on the effectiveness of community-based psychosocial support interventions. The evidence to policy partners you see here are working to address this priority, and they're doing this with support from the MHPSS Learning Collaborative, which has been built around the 5 studies that are being carried out by the institutions you see here on the screen. We have 4 USAID-funded studies looking at this question and 1 GIZ-funded study. You'll learn more about 3 of these studies in today's webinar, but they're being carried out by 10 institutional partners representing both research and implementing organizations. The studies are being carried out in 6 countries representing 4 global regions. And with that, I'll turn it over to Dr. Victoria No of the City University of New York to tell us more about this collaboration and the work that you're going to hear about in this webinar.
Thank you, Sam, for the overview of the HERD project. I'm Vicki No, and I'm an associate professor at the CUNY School of Public Health. I'm a clinical psychologist and also the director for the Center for Innovation in Mental Health, which serves as the technical lead for the HERD Implementation Science Collaborative domain area focused on mental health and psychosocial support. We're thrilled to be co-hosting this webinar with EPSA HC today. Our Implementation Science Collaborative MHPSS webinar series is focused on discussions that advance evidence to use priorities to inform policy and practice in low and middle income countries. We'll be hosting these webinars quarterly and look forward to sharing more about important research that help move the MHPSS agenda forward. Since today is the launch of our webinar series, I'm going to give you a little bit of background on the HERD MHPSS program and strategies we're using to support collaboration and promote translation of research to practice and policy. Since early 2020, URC and CIMH has been supporting the implementation of a portfolio of 5 hybrid implementation effectiveness studies focused on psychosocial interventions for communities exposed to trauma and LMIC. In a very important understudied areas, as many of you know, and has been even more relevant and critical in the face of a global pandemic and rising mental health crisis that we're seeing around the world. To support promotion and use of MHPSS best practices, we use a learning collaborative approach to support cross-study learning, share about implementation challenges and solutions, and foster research collaboration across teams. For example, one of the things we worked on early on is harmonizing study variables and setting up the study to conduct a cross-study analysis to assess collective impact of these interventions on key psychosocial outcomes, including mental health distress, well-being, coping, and functioning. We're also hosting an MHPSS Knowledge Hub, which maintains an online repository to disseminate resources and tools, directory of experts to foster collaboration across stakeholders engaged in MHPSS research, policy, and practice. And we welcome you all to join our network. Today, we'll get to hear about the work of 3 of the HERD MHPSS studies. The webinar today will focus on the discussion on the use of pilot and formative research in the design and adaptation of community-based psychosocial interventions, especially in response to COVID-19. It will highlight case studies using promising approaches, lessons learned, best practices, expert panel perspectives from the work of Heartland Alliance International, HIAS, and War Child in Colombia, Panama, Ecuador, and Jordan. Our speakers today will include Dr. Claire Breen, who is working with HIAS to develop and test an integrated mental health and protection intervention for refugee and migrant women in Latin America. We'll also have Dr. Felicity Brown, who's a senior researcher from War Child Holland, who will be speaking about a family intervention work with Syrian and Iraqi refugees in Jordan. Finally, we will have Dr. Leah James, a technical advisor from Heartland Alliance International, who will speak about their MHPSS intervention, which uses community problem solving and culturally based expressive activities with community agents in Colombia. After the presentations, we will have a live panel discussion moderated by myself and Dr. Paul Bolton from USAID. Our wonderful speakers will be joined by additional team members, including Dr. Carolina Vega Lagarda, who's a program coordinator from HIAS, Dr. Juan Fernando Botero Garcia, the research manager from Heartland Alliance International, and Michelle Ratner Costa, research manager from Universidad de los Andes. Lastly, we're happy to announce that we'll have live Spanish translations available during the panel discussion. To access this, please make sure to select the Spanish audio channel that's on your dashboard, on your Zoom dashboard. And also, please feel free to drop your comments and questions in the chat. We'll be sure to try to answer them during the panel discussion, or if not, we'll have the panelists respond to them and share their responses with you along with the recording of the webinar after the webinar today. So with that, let me first welcome Dr. Claire Breen, who's an assistant professor in the program on forced migration and health at Columbia University, Mailman School of Public Health. Her research focuses on improving the effectiveness and implementation of mental health and substance use interventions in humanitarian emergencies.
Hi, everyone. It's my pleasure to be here with all of you today. My name is Claire Green, and on behalf of my colleagues at HIAS, Columbia, and University of Copenhagen, I look forward to sharing a little bit about some of our research in Ecuador and Panama. So specifically today, we plan on discussing how we have used formative research to design and adapt a psychosocial intervention and its implementation across 3 diverse contexts. But to start with just a little bit of background and rationale for this work. So in recent years, we've seen increasing levels of forced migration in Latin America and the Caribbean, and we know that migrants in this region face numerous mental health and psychosocial challenges, significant protection risks, and disrupted social support networks, all of which have been aggravated by the COVID-19 pandemic. There are also unique and acute protection risks affecting displaced women, including high rates of gender-based violence, exploitation, among others. And we know that these protection risks and these mental health and psychosocial problems are very much related in a complex way that necessitates truly an integrated, or at the very least coordinated, multi-sectoral response that's appropriate for the culture, the context, and the population's needs. So in our research, we wanted to explore the feasibility of addressing some of these protection and psychosocial problems that displaced women are facing within the region. So we are working on this research in 3 sites. One is Panama City and some of the peri-urban communities surrounding Panama's capital city. We're also working in 2 sites in Ecuador. One is Guayaquil, which is a large urban coastal city. And the second site is Tulcan, which is a town on the border of Colombia and Ecuador, much more rural and often a transit point for migrants moving through the region. And so our goal here was really to examine how these different migration and displacement contexts influence the design and adaptation and implementation of a psychosocial intervention that's aimed at improving the well-being of displaced women in these settings. Our original plan was to integrate a very simple intervention, psychological first aid, into routine gender-based violence services. So we planned to train a set of protection workers providing GBV care to women and see, do the women who receive services through the GBV program report better psychosocial outcomes such as coping and emotional well-being and social support if their provider has been trained in psychological first aid as compared to women who receive just routine GBV and protection services alone. But prior to beginning implementation of this original plan, we started with some formative work to prioritize the protection and the psychosocial problems that were affecting migrant women and also explore appropriate intervention approaches. So through this process, we identified a few key pieces of information that made us reconsider or really just adapt our approach. The first, so through free listing, we identified some important sources of variation in the problems that women faced across these different contexts. So for example, in Ecuador, there was a lot of focus on some of the community dynamics and social tensions between the migrant and host population. And we generally found across the board that social, interpersonal, and community problems were far more salient than we initially anticipated or planned for, really, that our intervention was equipped to manage. Then in our key informant interviews, we identified that there was a really strong preference for a group intervention, some concerns about positioning this intervention within GBV services, given that we may miss a lot of women who could benefit from this program, and also some potential unintended negative consequences associated with having this intervention tied to GBV response programs. We also learned that it was important for us to consider including the host population and also ensuring that whatever intervention we selected or designed, it had to be adaptable across these different contexts, just given the unique implementation environment and population needs. So in response to this information, we adjusted some of our plans for the formative research. On this slide, the light blue shapes indicate the elements that we initially planned for our formative research. And then the dark blue shapes indicate kind of the components that we added once we had these preliminary results from our free listing and key informant interviews. So as you can see, we realized after the key informant interviews that we needed to think more broadly about our target population and how we define community. So our research teams engaged in some community mapping, some observational field work to really build relationships with community councils, with potential facilitators and other stakeholders in these communities, which proved a really important step for building trust and figuring out how to best introduce a psychosocial intervention within each of these contexts. And after this initial engagement process, we conducted some community consultation workshops where we invited community members to get input about the appropriate intervention or what that might be, which I will describe on the next slide. And then with this information, we tried to identify evidence-based or evidence-informed intervention components that aligned with the community's recommendations, which we then piloted through these mock sessions. So as displayed here, this was really an iterative process where we would consult with the community, test and identify and trial some of these intervention pieces, refine them, go back to the drawing board until we arrived at an intervention that we felt comfortable with and we felt aligned with existing evidence as well as the community's input. And then the last stage of the formative research was an implementation mapping workshop where we focused on how we should best implement the intervention that we developed in these different study settings. So here's a summary of the results from our community consultation workshops. So in these workshops, community members were given a summary of what we had learned in previous interviews and stages of the formative research. And part of this was the prioritized outcomes from the free listing interviews. And I'm showing some of the key ones on the right. And so what we asked the community members to do was to describe the types of activities or processes or things that they felt could improve these priority outcomes or modify these outcomes. And together, the participants started to generate these pathways that included the mechanisms or how they felt these outcomes could be improved, along with some key activities that they suggested could activate these different mechanisms and different pathways. So I'm showing kind of the 5 key mechanisms or pathways that came out across several of the consultation workshops and ultimately informed the development of the intervention and the selection of the components of the intervention. So with this information, we went back to the evidence and tried to identify existing interventions or components or principles or cultural activities and traditions that aligned with these suggestions to then incorporate that into our final product. So this is the final intervention manual. The intervention itself is called Entre Nosotras, which in English means among or between us. It is a 5-session intervention delivered by trained lay community members in pairs, which largely combine components of 4 interventions, including the Doing What Matters in Times of Stress coping skills intervention developed by the WHO, the community participatory action cycle, which is a big piece of this intervention, elements of psychological first aid, and then HIAS's community-based MHPSS curriculum. So in designing this intervention, we were constantly balancing the fit to each of the study contexts with the standardization across the context, and ultimately made the decision that we would allow for what we call flexibility in the form of the intervention components, but we aim to standardize the function of the intervention components. And what this means is that we tried to maintain consistency in the intervention's objectives and the mechanisms, but we allowed for tailoring of the specific activities and processes that were used to activate these mechanisms and to achieve the objectives across our different study sites. So just to give an example, the objective of the end of the final session of the intervention is to promote solidarity and group connectedness and commitment to future collective action. So in Ecuador, the 2 sites achieved this through Pamba Mesa, which is a traditional communal meal that symbolizes social solidarity. In Panama, however, the final session closes with participants sharing a small craft or bracelet that they have made for another member of the group, and then sharing kind of what they've learned from that group member, from the group more broadly, and how they plan to sustain the group. So each of these activities shares the same function of reinforcing social connectedness and sustained group identity, but applies a different form that really fits the local context and traditions. So some key reflections on how this formative research contributed to our intervention. First, I would say that having these parallel but harmonized processes allowed 2 different types of learning. First, the cross-site learnings really promoted innovation and creativity as sites could kind of learn and draw from what others were doing, whereas the within-site learning really allowed us to increase fit and maximize feasibility and appropriateness of the intervention to each context. We also found that through this extensive formative process, having that early community engagement and being responsive and flexible to the priorities of the community really generated strong ownership and commitment from the people that we engaged with early on, many of whom moved on to become our intervention facilitators. And we also found that we had to be really flexible throughout the design and the adaptation, in the research plan and design, and also more broadly in implementation to account for the differences across sites, as well as kind of external factors such as COVID-19. So with that, I'll just say thank you for listening, and I look forward to further discussion in the webinar.
Thank you, Dr. Green. Our next speaker is Dr. Felicity Brown, who's a researcher and clinical psychologist with a background in developing and evaluating psychological interventions for children, adults, families that are affected by armed conflict, poverty, and other adversities. She's currently a senior researcher for the Middle East region in War Child Holland's R&D department.
Hi everyone, my name is Felicity Brown. I'm a senior researcher working for War Child Holland. I'm currently based in Amman, Jordan. Let me share my screen and get started. So tonight or today, wherever you're watching, I am presenting on behalf of quite a large study team. So we are funded by GIZ Regional Program in the Middle East, and we are working in Jordan with Collateral Repair Project. So the aim of our project is to develop and evaluate a family-focused intervention in Jordan. And for this talk, I'm going to focus in on how we are working alongside local advisors to inform the intervention development as well as the research design. So as a quick background to our project, so we know that families are essential for children's positive well-being and development, yet many of our approaches tend to work individually with children or parents rather than working with the family as an interconnected system. We know that stress from adversity can impact all members of the family, but it also impacts how family members relate to one another and how they're able to support each other. When we're working with vulnerable families, we also often see a convergence and compounding of multiple problems all at once. But on the flip side, we also know that families are often the primary source of support for individuals. So as one Iraqi father mentioned about his wife, she became a back belt support for me. She made me stronger in dealing with difficult circumstances that we lived through. Sometimes I feel moments of collapse, and she is the one who reminds me not to do this and not to do that. So she strengthened me a lot. At the moments that I get angry and after I calm down, I hug her and cry. So based on all of this, the aim of our study is to develop and test a systemic family intervention that can be delivered by non-specialists. We're working in Al-Hashmi Shimali community, which is in East Amman, an urban area. It's characterized by high levels of adversity and has high populations of refugees. The populations that we're working with are Jordanian families, Syrian and Iraqi refugee families. So this is the overview of our study. It has 3 phases. So in the first phase, we conducted a review of existing programs in Jordan, the Middle East, and also globally. We conducted interviews with families and practitioners in Hashmi. And we also conducted a series of theory of change workshops and intervention development workshops to develop our intervention. At the moment, we're in phase 2, where we're conducting a case series study with 12 families. And the next phase will be next year, where we'll be conducting a pilot RCT with a larger number of families. So in setting out to develop and evaluate this program, we had many questions, including around gender and intergenerational dynamics and how we can best train non-specialists to manage this when working in a family system. Cultural sensitivities around talking about family issues with outsiders. We also had questions around how we measure outcomes at the individual level, but also these relational outcomes that are very different to typical like symptom or well-being measures that we might normally use. And we also had questions around how best to identify at-risk families who need MHPSS. Again, it's a different kind of question compared to looking at people with high levels of individual distress, and also has many sensitivities around it. So in order to answer these questions and also many other questions that we had, we engaged 2 advisory boards. So the first being local study advisors. This consists of 6 families representing the major participant groups in our study. And we also engaged a community advisory board, which is consisting of 5 practitioners with extensive local experience in Hashmi community, delivering various support services. So I'm going to talk through each of the phases of the study and how we have incorporated feedback from these boards. So firstly, in terms of conducting the interviews with families, both the CAB for short and the LSA for short helped us to develop a vignette description of a family that was struggling and use this to identify families to interview, families that were having troubles to interview. For the CAB, so these were the practitioners themselves, we asked them to help us identify families who met the characteristics in this vignette, so families that were struggling, but we were also interested in interviewing families that were coping quite well despite the adversity. We thought they were also important to interview. And both boards also helped us to review the preliminary findings and helped us interpret and validate our findings. So just as a quick specific example, so we had reports of substance use being an issue, but sometimes they were vague in terms of prevalence and also types of substances. And the CAB and LSA were able to let us know that, yes, the prevalence is higher than probably reported by individuals. And yes, it can be prescription medications, but it can also be alcohol, whereas many people are not that willing to disclose about alcohol because of the religious and social taboos. In terms of intervention development, They both helped contribute to the theory of change for the intervention in terms of prioritizing outcomes and developing the mapping of the theory of change. And they validated our intervention concept. The LSA specifically assisted in like cultural and contextual adaptations to the core concepts and activities that we proposed via a series of workshops and also experiential exercises where we went through the activities. They also provided us with examples to include throughout. So one specific example is that both boards highlighted specifically for refugee families the importance of continually recognizing the inability to put down roots as a persistent stressor affecting these families. So this was integrated throughout the manual, specifically when implementing it with refugee families. In terms of informing the current phase of the case series with 12 families, the LSA contributed significantly to the outcome measures. So they helped in decisions around which outcomes specifically to measure and to prioritize and to measure. We selected validated tools we prioritized ones that had been trialed before in the Middle East, but they helped us to, to validate culturally the selection that we made. And they proposed additional items that were missing to capture salient concepts. And we also then ran through a cognitive interviewing process with them where we showed them the questions, children and parents, and ensured that the questions were being understood as intended. So as one specific example, we had an emotional regulation measure, but the LSA told us, it's really missing something that's really important when it comes to emotion regulation in our kind of culture, and that's that you tend to withdraw from people you care about. This is related to low ability to regulate emotions. So we added this item. In terms of the program delivery, both boards contributed to selection criteria for families, development of the tools used to outreach families, and we're also able to help think through key implementation factors such as gender and nationality matching of facilitators, outreach and retention, and the process for selecting, advanced modules for the families to take in the intervention. They have been continuing to provide us advice on overcoming challenges in scheduling and also on referral options. So one example was we had many discussions about home versus center-based sessions. The initial preference from both was to conduct center-based, just due to acceptability of visitors in the home and also space available in the homes. However, we've been having challenges with scheduling at the center and also transportation allowances not being sufficient. So the CAB has strongly advised to reconsider home-based sessions, and this is something we'll be discussing in the coming period. In terms of reflections, I wish I could talk about this for longer. Hopefully we can talk more in the panel discussion and I can also hear from everyone else. But it's been a mutually rewarding experience, I would say, is at least what we've heard from the board members as well. Definitely, I feel that our program and study are better grounded in the reality of the Hashmi community. Face-to-face meetings have definitely been more fruitful, particularly in having discussions. But this has been challenging due to COVID and preventing face-to-face activities at times. It's also been challenging to get the whole family to attend. We really hope to have mothers and fathers and children's voices in the boards. But what has ended up happening is typically there's one representative of the family that attends regularly and other members attend sometimes. This is something we really hope to overcome. The CAB, which is the practitioners, we had initially planned for less frequent meetings and only meetings at certain time points given how busy practitioners are. However, they have requested more meetings, and we actually also see that this is really important in order for them to follow along and be regularly updated on the study. So we hope to be able to meet with them more often. Next webinar, we can hopefully have one of the members join a presentation, but also just something to highlight is, one of the main challenges in working with, with community advisory boards is just the difficulties in our current project structures generally, outside this project as well. But just in terms of when our project designs and budgets, plans and contracts need to be planned in advance, it's sometimes challenging to then balance that with getting meaningful participation in decision-making around the projects. So this is something I would love to discuss more if others have experiences with this as well. Thank you very much. I'm out of time, but I'm hoping that we can discuss this more in the panel, and thanks so much for listening.
Thank you, Dr. Brown. Our final presentation is from Dr. Leah James, who is the Global Mental Health and Psychosocial Support Technical Advisor for Heartland Alliance International. She's currently based in Cali, Colombia. She has experience designing, implementing, and testing MHPSS and gender-based violence interventions in humanitarian and development contexts, including projects in Colombia, Iraq, Lebanon, Malaysia, Nepal, and Haiti.
Hello, everyone. My name is Leah James. I'm the Global Mental Health and Psychosocial Support Technical Advisor for Heartland Alliance International and a co-principal investigator on the project that we'll be sharing about today. Really happy to have the opportunity to speak with you. I will be discussing a project conducted by Heartland Alliance International in collaboration with Universidad de los Andes, focused on evaluating the effectiveness of a community-based psychosocial support intervention for communities affected by violence in Colombia. And in particular, we'll be sharing about adaptations that we've made for COVID-19 context. This project is set in Quibdó, which is a city on the Pacific coast of Colombia that's been extremely affected by Colombia's internal armed conflict, including ongoing community violence. The target population are adults who are victims of the armed conflict, who have been displaced by the conflict. The majority are of Afro-Colombian descent, and we also have Venezuelan migrant participants in this project. Colombia in general and Quibdó in particular have been highly affected by the COVID-19 pandemic and related lockdowns, as well as during the past year by mass protests against inequality and police brutality, by acts of police violence in response to those protests, and by resulting resource shortages and transport difficulties. The objective of our project is to test a community-based psychosocial support group model that HAI has used in Colombia as part of its Acople project over the last decade. This model is facilitated by non-professional community members called community psychosocial agents, who are trained to provide services to their peers and are supervised by mental health professionals. The group model includes 8 weekly sessions consisting of collaborative problem-solving skill development, drawing from WHO's Problem Management Plus model, as well as expressive activities that draw from cultural practices such as artwork and dance. We originally planned to conduct the intervention in person and to test its effectiveness through a mixed method study to assess implementation science outcomes, as well as effects on participant distress, well-being, coping, functionality, and community efficacy. We planned a pilot in which we would collect pre-post data in order to try out the newly adapted protocol manual and the research tools, followed by a randomized controlled trial to more rigorously test the model. We collected data through quantitative interviews conducted with participants pre and post intervention, qualitative interviews conducted with a subset of those participants, and a focus group discussion with staff. And of course, we plan to do all of this in person in the community setting. Then the pandemic happened and everything changed, everything shut down for a period. HAI's services globally began to move to remote modalities by phone and internet. But while it's one thing to provide individual mental health services remotely, the team really scrambled to figure out if and how we could adapt community-based group models to remote modalities, especially in the low-resourced and partially rural areas where we were working. Ultimately, we decided to use the pilot to try out a variety of modalities. An in-person group with COVID safety precautions such as social distancing and PPE, a remote group using phone and internet-based platforms, and a hybrid group, meaning that some of the sessions, the one focused on problem solving, were conducted remotely, while the expressive activities were conducted in person. We ran 2 groups in each modality for a total of 39 participants. So we made a series of adaptations for the remote sessions with input from the community agents and participants. First of all, we conducted the remote sessions using Zoom so that those who wanted to and were able to join with video could do so, and participants could also make use of the chat function, which is useful in a group. You can see images of this here. And we also made it possible to call in by regular phone free of cost for those who didn't have a strong signal, so this could be used as a backup option. Because not all participants had smartphones, we created a smartphone lending library, and we provided phone credit to everyone. We provided training to both the community agents and the participants on tech literacy, including how to work Zoom and also ethical considerations. So related to this, we created tailored consent forms explaining the risks and benefits of each kind of approach. And we also created a safety planning for remote service delivery checklist to try to address confidentiality and safety concerns, such as the possibility that participants joining calls might be overheard by other family members, which is a real risk when discussing sensitive topics like mental health, and for those who might live with perpetrators of violence. So this checklist was designed to be completed by community agents with participants and included things like identifying a code word to say when somebody else came within hearing distance. We also worked to adapt the session content to remote and hybrid modalities, which was very tricky, especially for the expressive activities. We arranged for supplies like notebooks and art supplies to be delivered to participants, as well as snacks, which we all know are a critical part of any group experience. Then finally, based on the results of the pilot, which I'll discuss more in a minute, we decided to conduct the RCT using 2 modalities, remote and in person, and to allow participants to choose which modality they preferred. Okay, so lessons learned from the pilot. We were happy to find that all 3 modalities were feasible overall, despite some attendance challenges in all modalities. Across modalities, participants showed significant reduction of distress and improved well-being from pre to post intervention. There were some interesting differences on the coping skills measure. For example, that use of social support as a coping mechanism significantly improved in the in-person, but not the remote modality. And the hybrid modality was somewhere in between. On a satisfaction survey, participants reported that all modalities felt safe from COVID and that they were overall highly satisfied. We were able to learn more about the challenges and benefits from the qualitative data, both from the pilot and what we're starting to hear from the RCT, which is just finishing up. So in regards to challenges of remote sessions, we had the usual players, connectivity being a big concern. Also, perhaps the use of connectivity issues being an excuse for participants to drop off calls, because community agents reported that they did drop off more often when the conversation became emotional. So confidentiality and privacy issues, both from taking calls at home and from use of social media. And perhaps unsurprisingly, another challenge was that it was harder for participants to form meaningful connections with each other in the remote sessions. So it seems they were overall seen as sort of more instructive, kind of like being in school, and less collaborative, which is certainly not ideal for a community-based group intervention. On the other hand, we also heard about a number of benefits, such as ease of scheduling, not having to travel to the community center and therefore be exposed to community violence, and also fewer issues with COVID risk from public transport and dealing with transport disruption from the protests. In general, the remote groups were preferred by younger participants. And although we don't have the full RCT results, we do know that while both modalities had some attendance issues, the remote sessions were actually better attended than the in-person sessions. Another lesson learned is about the importance of thoughtfully adapting staff training, supervision, and staff support services to remote modalities. And we found that the staff support piece was especially critical, as of course the pandemic was and is highly stressful for everyone, as is providing these kinds of services in general. So HAI's Columbia team provided regular staff support sessions by video call and WhatsApp, later through in-person activities with PPE, as you can see in the pictures here. In regards to implications, we found that community-based interventions are feasible, and there's some initial support for them being effective in these three various modalities. Although there may be some important differences in how people benefit, in the sense that social support may not work as well in remote sessions. I think this is really important information, both for the COVID-19 context, but also because there are many other contextual factors that may necessitate remote sessions, such as community violence or for transitory migrants. A key lesson that we learned is that in order to ensure equitable access to services, whenever possible, we think it's important to have services available in multiple modalities to educate participants about risks and benefits of each type of modality, and then to allow them to choose their preference. And giving them decision-making authority here is really critical, because various factors that differ across individuals and groups can mean that in-person or remote groups just aren't workable and result in a sizable chunk of participants who choose not to participate at all. So for example, connectivity just isn't resolvable in some cases, access to devices and tech literacy, scheduling needs, community violence and transport disruption. And then of course, participant preference really matters, and comfort forming remote versus in-person relationships. And finally, in order to make remote services as effective as possible, we think more work is needed to understand how best to transfer benefits of peer support frameworks that are so critical in community-based work, in which healing results from participants giving and receiving support to their peers, how to transfer these benefits to remote modalities. The field is currently learning a lot about how to provide services remotely, but helping participants to make these connections to build cohesion virtually is a key element of this that needs more attention. So I want to thank you so much for your time and your attention. I also want to thank the team who collaborated on this work, including Juan Fernando and Michelle, who are here to answer your questions in the panel. Of course, big thanks to URC and USAID. And please feel free to be in touch with us by email if you have questions or feedback. Thank you. Take care.